everyone, welcome. My name is Naomi Balabudro and I'm the CEO of the Deep River Library. I'm here this evening with my colleague Alex Stevens, who is behind all the tech over there. He's joined us in the role of digital services as well, and we're thrilled to have him. He's doing a really great job of recording these sessions. There's actually footage you might want to watch. And we're pleased to announce that we've got the drones presentation and the last presentation up on our YouTube channel. So we will be sharing that a bit more widely in the future, but you can find at least those two and hopefully some of the others shortly. I would like to start this evening by recognizing that we gather on the traditional unceded territory of the Algonquin and Anishinaabe people. We honor their rich history on this land and work to include and celebrate Indigenous knowledge and stories in our collections and our services. We recognize that we're all on a journey of learning together as we work towards truth and reconciliation. My coworker Elizabeth has put together a pamphlet, which I have a few at the door if anyone is interested, looking at the history of this land specifically before the town was built. A few housekeeping items before we get started. The washrooms are in the hall, as you probably know. The emergency exit is just outside that door and to your left. If you need help leaving the building in case of emergency, please gather in the stairwell and we will assist. The elevator will soon be working, but is not at this time. Soon. We have coffee and cookies, and we always hope you'll stay for further conversation after the presentation. But for now, I will pass it over to my colleague, Mike. Sorry, one more thing I forgot to mention. I just wanted to highlight the art that is on the wall this evening, helping make this room a little bit more beautiful. So we wanted to thank the artists and the Library Arts Committee for facilitating that. And there will be a opening tomorrow afternoon with some of the artists between 3 and 5. So if you're out and about around town for all the festivities, come drop by. Okay.
Thank you. Thank you. My name is Mike Milgram. I'm I guess destined is the word to introduce this every talk. I have 3 duties up here. 1 is to introduce the seminar series, 2 is to introduce the speaker, and 3 is to think of a different way of saying this every time. So I think hopefully I've just succeeded at that. I'll remind you that at the end we have a collection jar at the door, and we hope you will make a exit donation. The money goes to the Deep River Food Bank, and I can report that last talk we collected over $200 for the food bank, plus 1 washer. We're not quite sure how to interpret it, but if anybody wants to claim it, it's right here. The seminar series, to remind you, we've had 2 talks, one by Dave Beatty on drones and one by Phil Deacon about his visit to the telescopes in Chile. And I should add that the word of this series has gone around the valley, because I had a communication from someone in Perth who wanted to know how to contact one of our speakers. They want to get him to give a talk down there. Tonight we will get a talk by Mark Ungrin. I will introduce him in a moment. And to remind you of what's coming while I have a captive audience, Brendan Quine, who is the CEO of Thoth Technology, that is the people who run the telescope in Algonquin Park, and who has bought some of us will know as the old dairy. I've now done some research, and I can tell you that some of the technology that he has is quite astounding. He has a capability of detecting a football-sized object in geosynchronous orbit. That is up to 100,000 kilometers away. He can pick up a football, and he can tell you which way the solar panels are facing. and he can do it in such a way that if you happen to, that the inhabitants of the football will not know that they've been pinged. So next talk is by Brendan Quine, followed by Anne Stradula, who will talk about lost villages of the St. Lawrence Valley, where she grew up in a town that is no longer there. John MacDonald, who has built numerous timber frame buildings around town. We'll talk about his life as a timber framer. And then Richard Wilson will talk about diseases of trees. And I believe that will be particularly about the diseases of oak trees. I'll remind you that I almost certainly have next year's series filled up, but there are a couple of question marks. So there are people in this room who are doing interesting things, and do you want to talk about them? That's what this series is all about. Please contact me or Naomi, because I'm starting to make a list for the year after, but we may actually be able to squeeze someone in for next year. So I believe that's everything I have to say about the series. And now for our speaker, Dr. Mark Ungrin. He doesn't say that he grew up in Deep River, but I will add that. Is a transdisciplinary researcher whose work focuses on the efficient translation of biomedical research into societal impact, integrating basic science, technology development, and the importance of research into integrity and reproducibility. Associate professor at the University of Calgary. And this is interesting because he's affiliated with 3 different departments. And when I asked him, he wasn't quite sure which one was his department. But apparently it's the Faculty of Veterinary Medicine. He completed his undergraduate degree in biochemistry, worked in the pharmaceutical industry, obtained his PhD in cellular and molecular biology at the University of Toronto's Department of Medical Biophysics, followed by postdoctoral research in the Institute for Biomaterials and Biomedical Engineering. His work has been funded by all 3 of Canada's tri-agencies, and he served on the Scientific Advisory Committee in the development of the standard for good cell and tissue culture practices. His AgriWell technology is under license to Stem Cell Technologies of Vancouver. It is an international standard organized research in use around the world and on the International Space Station. And one thing I should add is if there are questions, he's asked to save them to the end. We'll have a guest, depending on how long he talks, we'll either have a question period right after or we'll have a break followed by a question period. So, Mark?
All right. Thank you very much. If I'd known he was going to have to read the whole thing, I would have given him a shorter paragraph. Sorry.
I didn't read all of it.
Oh, okay. Yeah, I gave him the boilerplate, and I figured he could cherry pick. But okay, so yeah, science, pseudoscience, and public policy. And actually, just before I get started, is everybody good with who needs to see the closed captioning? I got a couple microphones on already. I can, one more wouldn't hurt if anybody needs one. But okay, so there's kind of a usual way to approach this topic, right? And it involves me pointing some fingers and telling you whose fault everything is. And then if there are people around who have some of those opinions, they shout at me and everyone shouts at everyone. And we don't necessarily learn all that much. So this is a talk I put together I did the keynote for the Canadian Association of Biological Safety. They had the Canadian Biosafety Symposium in Ottawa in September. And I wanted to try something that, just like a little bit different. We kind of know how that usual conversation goes, right? So let's just assume we've gone through it and then kind of move on to something else. So just before I really get going, introduction. So as Mike mentioned, interdisciplinary researcher. I'm married to a medical doctor who had to close her practice due to long COVID a couple of years ago and still hasn't recovered. I'm an advisor to the Canadian COVID Society and co-chair of their legal committee. Co-author on, as far as I'm aware, the most up-to-date interdisciplinary review on masks and respirators for dealing with respiratory diseases. The link is down here. I'm going to turn this into a PDF, and that will be available afterwards. All of the references through the talk are going to be clickable links in that PDF. So if there's anything you kind of want to dive into in any more detail, you should be able to just download that and click through and follow up.
Mark, could you talk into the microphone?
Okay, is this better?
Ask them.
A little bit.
Oh, a little bit closer? Okay, yeah.
If you're 2 feet away, are you wearing a mask for COVID or
Yeah.
prevent breathing? Because if you're and there's just a suggestion, if you're 2 feet away, you may not need the mask.
Well, so you're going to be interested in some of my slides here. But okay, yeah, no, I'll keep this here for now. Yeah, so vaccinated and boosted, and happy to discuss why it's a good idea. Ask the hard questions. We will save them for the end, but sometimes, depending on the context, right, there's a feeling like you have to be a little bit polite, right? Don't challenge this, like, this was generated as a scientific talk. I would rather you leave this room thinking, man, we were kind of hard on that guy, rather than thinking, oh, well, he didn't really address this question I had, right? So, don't be shy. We'll save it for the end just so we, have time kind of thing. But yeah, don't, go ahead and ask the questions. Okay, so just before we get going, human error is not a cause, right? One of the most common findings in incident investigations across fields is human error. But the problem is human error is predictable, right? And so if we have a system that allows human error to, a predictable event, right? A predictable challenge. If we have a system that can take a predictable challenge and turn it into a significant failure, that's a systems problem. So we can't just stop when we get to human error. And it doesn't mean there's not a place for accountability, but we have to also learn from the failure and build systems that are robust to human error. And when the same errors are repeated, we have to ask, well, why is the system creating those errors, right? What is it contributing to them? Where are they coming from? So human error is at most a component of a bigger systems failure, and it's often an excuse just to stop thinking about the problem, right? We pick the most junior person in the room, we say that person did something wrong, and we leave it at that. So an example here, Vigie Mont-Royal was well, still is, I guess, a seniors residence in Montreal. Got hit by one of the early COVID outbreaks in May 2020. 273 residents, 68 deaths, right? So that's really bad, right? Already at this point, there had been warnings that COVID was airborne. When it came in, the nurses were asking for the PPE, for the N95s. So these are all quotes from the story down here, the news story. But yeah, no isolation zones, wasn't providing PPE, no N95s, no test kits. They were bringing in staff from other sites, and within, same day they were getting infected, symptoms, etc. Then the military came in, and they take this stuff seriously, right? They didn't know what it is. They didn't need to know what it was. They have their protocols in place. So they started wearing enhanced PPE, N95s, cowls. And here's some, quotes around that. 50 soldiers, nobody got sick. None of the military personnel is sick, right? So there's a learning opportunity. There's the chance to say, oh, wow, go up to the nurses, sorry, we apologize, you guys were right. Let's change how we do things and move on. So do we think that's what happened? Anyone here a nurse? So, okay, yeah, so do you think they did that? They said, sorry, nurses, yeah. What do you think they did?
They just went ahead and did whatever they wanted.
And they blamed the nurses, right? I think there's probably other factors than the ventilation, lots of objects to clean, less people working. They had pressure. They probably didn't apply the things correctly, right? I mean, probably, right? Like, it's just an opinion. We had data, right? But yeah, probably the nurse's fault. And so this is the problem, totally apart from the injustice of the whole thing, right? Is, focusing on human error it's a get out of jail free card, right? You can just say, well, it's that person's fault. We don't have to think about it anymore. We found who to point the finger at. We can walk away. So misinformation now. Okay, so there's this, really important false dichotomy around misinformation. Most of the discussion that I run into around misinformation is very simplistic, right? You're either with us, you're against us. There's two sides, and you either are on the side that said, everything's fine, I've had my vaccine, everything's back to normal, I'm going out for brunch, right? Or you disagree with that, and then you're on the side of all the other things that, okay, well, you're saying things are not okay because microchips, 5G, and the, whatever, right? And you can't have any other opinions. And that's unrealistic. These conversations are often led by institutional voices, and they frame misinformed beliefs as human error, right? Often associated with claims of stupidity, malice, right? Like these people believe silly things because they're bad or stupid or whatever, right? That's not helpful. The solutions generally that get proposed generally involve shouting at people and or punishing people for saying things on social media. So limiting what people can say or just shouting, getting some money and shouting louder than they can, right? And that's not really about learning. It's about obedience, right? And it's not coincidence. Am I making that noise? Right. It's about obedience, and it's often not a coincidence that, again, links back to these institutional voices. And it also doesn't work, right? Like we've been trying that for quite a while, and it doesn't help. We'd know by now if that worked, right? And the important piece that comes out of that when you look at a deeper level is misinformation doesn't just appear, right? The first time we encounter it might be on a protest sign, but that's not where it came from. Just about all of these claims can be traced back to something in the scientific literature, right? So this one, the Lancet here, this is the Wakefield paper that started the whole, anti-vaccine thing, right? And that took 12 years to get retracted from the Lancet, right? So it's kind of an unreasonable expectation that, somebody waving one of these signs is going to look at the Lancet and say, oh, well, that paper is poor quality for this reason, right? So we have to kind of move upstream and say, well, these people aren't the source of the problem, right? We have to kind of move up the chain and say, well, how do these things get there? How do they persist? And also this business of things are okay, things are not okay. Well, things aren't okay. So this is a 3-year study from the US Veterans Administration. So the N values are down here, and they're absolutely huge, right? This is a really big, robust study looking at the impacts following COVID, right? So for each of these blocks, you've got different conditions, interstitial lung disease in this case, looking at the fold increase after a COVID infection. The upper half is people who did not get hospitalized after the original infection. The lower half is people who were hospitalized 1 year, 2 years, 3 years later. So for interstitial lung disease, people who were hospitalized with a COVID infection, the 3rd year afterwards, they still had more than twice the incidence of ILD than the control population. And everything, so the ones in gray are not statistically significant, so you can ignore them. Everything in color is statistically significant. And again, the link's going to be here in the PDF, so you can dig through it yourself afterwards. And so just pulling out, the neurological thing, right? Like got Alzheimer's, Bell's palsy, epilepsy, hearing loss, stroke, right? Like it's a ton of stuff. And that's a big table, right? So there's a lot going on there. And so when we say, well, either you have to believe that everything's okay, or you're hanging out over there with RFK, right? Those are only 2 choices. Some people are going to look around and say, well, you know what? Things are not okay, right? And it goes beyond that. So, and again, all these things are linked to the original sources. So across the OECD, and this is OECD data, long COVID burns about 7 million years of human life annually, up to $1 trillion out of the economy, and keeps 3 million people out of the workforce in the OECD alone. Driving the longest period of peacetime excess mortality on record, that's from the life insurance industry. There's no cure. Each infection is a new roll of the dice. That's StatsCan data there. Public Health Agency of Canada warned the provinces it was coming in 2020. So that's the fact slide deck from 2020. And Canada's Chief Science Advisor has called out our public health agencies for gaps in public messaging about the importance of prevention. So it's serious, it's preventable with particularly N95s and better ventilation. And it's pretty straightforward, right? If it can't get inside you, it can't make you sick. Vaccines also improve the odds. So like, why aren't we hearing more about this, right? So we need to talk about the elephant in the room. I was particularly proud of that slide. Okay, so the context, the very big mistake. So these are both from the World Health Organization. March 2020, COVID is not airborne. Not a lot of nuance in there, right? There wasn't any kind of, well, maybe we don't know, maybe you should be, COVID is not airborne. So that's 2020. 2024, airborne transmission. And that's a huge deal because you can't mitigate a pathogen properly if you're not understanding how it gets around. And I'll also just highlight here, because we'll come back to this, a couple of statements here. Too heavy to hang in the air, quickly fall on floors within 1 meter, right? So there's your 1 meter range that we heard all about through the beginning of the pandemic. We'll come back to that. So this is a quote from the World Health Organization's former chief scientist and current associate director general. He got a recent promotion earlier this year. Interviewing Der Spiegel, the German news magazine. So even the WHO didn't take the spread via aerosol seriously, which is correct, right? And he says, yeah, that's a very big mistake. We could have prepared better, et cetera, et cetera. That would have saved an enormous number of lives. So at this point, it's not about winning or who gets to control the narrative, right? Mistakes that kill an enormous number of people are bad, right? Like, we should do something about that. And we have an obligation to learn from that failure. So the misinformation isn't just one-sided, right? There's a lot to go around, and that's why it's important that there's more than two options, right? You don't have to pick one side and believe everything from that source and ignore everything from elsewhere. You can kind of, move orthogonally to that axis and look at other things. And related to that, the foundation of public trust is trustworthiness, right? We hear a lot about the need to build trust in science and create public trust in science. As if it's this thing that you can just magically do or force people to do or trick people into doing, right? But actually, I don't know that we need to worry too much about building public trust in science. We need to demonstrate transparency and trustworthiness, right? In a body of knowledge and be open to questioning and everything. And then the trust follows naturally, right? We're not going to convince people by shouting at them, but if we demonstrate that, yes, okay, we understand this and this is how it works, we'll have more luck. So, what if we had just followed the book, right? So this is a bit of a complicated figure, but CAN CSA Z94.4-18 is the current version of the relevant national standards on selection, use, and care of respirators from 2018. So this was enforced before the pandemic hit and has been ever since. Generated by experts from across disciplines here. And and of course, the whole standard's like a couple hundred pages. It's huge, it's complex, but this is the quick reference figure, right? Figure 2 and 4, I think, yeah. So when COVID first hit, risk group 3, right? There's been a push to downgrade to risk group 2 since, but it doesn't really change anything. So that means that on this chart, you're looking in this quadrant here, the R3 quadrant. And then C and G, you can look at this afterwards, but it's essentially, just generation and air turnover and things like that in the space. But the most important thing to notice for now is just that there's no number in this quadrant lower than 1, right? Up here, we have some zeros and little white boxes, but there's none of those down here. So under the standard, if this bioaerosol hazard may be present, the lowest level of protection that's acceptable under the standard, green 1, comes over here, negative pressure half phase place, including filtering phase pieces. So that's N95s, right? Not medical masks. Control banding approach for bioaerosols. So this isn't just random aerosols. It's specific to disease carrying or human generated, animal generated in healthcare facilities, right? So, the standard isn't often like provincial legislation is a couple generations behind the standard. It takes a while to get the standards incorporated into the regulations, but this is the current standard, and it is applicable in some. I think the federal labor code actually just refers to the current version, and 1 or 2 provinces maybe. But anyways, okay. So prevention is critical, right? Vaccines work. It's much better to trigger your immune system with a little bit of the virus, not the entire genome. Controlled dose, controlled timing, rather than doing the same thing with the whole virus. It's reproducing, it's got all the bits in there, it's doing all of the things the virus does to you when you're not ready for it, when you're tired, However, it's still not a trivial ask, right? Like if I come in here and I have a syringe full of something and I say, I have 100% conclusive proof this is safe, but I want to inject this into you, right? Even if you believe me about it being 100% safe, you're still going to want to know a good reason, right, to accept that. right? So vaccine mandates can be justified, but you've got to recognize it is not a trivial ask. And you've got to try the other options first, right? And that's what we didn't do with COVID, is like ventilation, right? That's the first one. Clean air. Again, if it doesn't get inside you, it can't make you sick. The virus doesn't get in, the virus can't make more virus. If we clean the air, if we pump it through filters, if we bring in fresh air, that makes things better, right? Then second tier from that is masks. And if we start imposing mask mandates on people, and we should do it with good ones, N95s, right, the appropriate PPE. So far as I know, nobody objects to this, right? To masks, some people do, but again, you know, it's a little bit, I mean, it's in your face, right? A little bit more than a improved ventilation system, right? And then the third one is, yeah, you get to vaccines. So again, I think there are circumstances where vaccine mandates can be justified, but you know, it's not unreasonable for people to be upset that we jumped straight to this, right? Without doing the other things first. That really should have been done, right? There really isn't much of an excuse for that. So that's maybe some of the motivation, some of the things that get people upset about these things. So now let's start digging into the misinformation itself. And yeah, so it's valuable to look at, you know, not just kind of this general category of misinformation, but to break it down into individual claims and ask, okay, well, where did that claim come from, right? Why does someone believe that, right? Because it's easy in a general sense to say, oh, well, people are misinformed. They don't know what they're talking about, right? But I mean, by and large, everyone's pretty well-intentioned, right? People aren't going out there deliberately trying to come up with illogical beliefs, right? People may have limited access to different sources of information, but generally people have a reason for the things they believe. So you can ask, well, where did they get that idea from, right? So what I'm going to do here is walk through a number of claims that have been made that we have tracked upstream to the original kind of literature sources, right? The original publication that people will say, no, there's a scientific paper that says X, right? And then taken a closer look at the paper and said, well, you know, and we haven't bothered with fringe literature and the really weird stuff, right? Like, I mean, you can always find junk in the really kind of extreme things, but we focused on actually, you know, mainstream journals, mainstream medical literature. So what I'm going to do is go through those individual claims and just look at the kind of the failure modes that are repeatedly associated with them. So here's one. Masks, and N95s in particular, are harmful, right? So going back to this paper, significant changes to respiratory physiology caused by breathing through N95 mask materials, right? So that sounds pretty scary, right? And they were looking at, pregnant healthcare workers. So they did their tests with nurses who were pregnant at the time, and there's significant changes in respiratory physiology. And of course it's concerning because there are standards or certification like this should be happening, right? Okay, so once we started digging into the paper, here's their experimental apparatus. So a spirometry mask, so there's a little turbine in here, right? Sort of rubbery elastomeric masks that seals well over the face, straps and everything else. And they put that on the nurses and they had them do a bunch of stuff. And then what they did is they cut a little piece out of an N95 respirator and they taped it over the hole, right? Simulating the actual wearing of an N95 respirator. And those of you who've done some thinking about mass balance and things like that are maybe already seeing what the problem is, because it's a tiny little hole, right? So we got in touch with the manufacturer of the turbine here and everything, but you know, did a little bit of math and a little bit of image analysis just to kind of check our numbers. And the cross-sectional area of this piece cut out of, I'm pretty sure it's either an 1860 or an 1860S 3M mask, is less than 10% the surface area of, you know, a full N95 respirator that it was cut from. So just from the perspective of, you know, if you're going to breathe the same volume of air in the same period of time with a 10-fold reduction in cross-section, it has to move 10 times faster to go through that material, like to get the same volume through. In this flow regime, resistance is roughly directly proportional to velocity. So there's a 10-fold increase in resistance, And that means the entire study was carried out under conditions equivalent to wearing 10 N95s, one on top of one another, with the edges very well sealed, right? And so it's completely irrelevant to real world conditions, right? Nobody's gonna wear, maybe somebody might 2 or something for some reason, maybe, but nobody's gonna stack 10 N95s on top of one another, right? So completely meaningless. So human error, at one level, yes, obviously there's an error there, right? But it doesn't really help us to stop there. So published in Antimicrobial Resistance and Infection Control, that's a pretty mainstream clinical journal, right? What happened to peer review, right? Not just publication, but when they were funding the study, when they were doing ethics review. If you look at the resistance of these things, we actually went through the standards around the requirements for certification of respirators. This is probably around at least triple the, there's an upper limit for breathing resistance that an N95 is allowed to have to meet the certification to be an N95. And with 10 of them, that's going to be about at least triple that limit, right? So, there's issues around ethics just you couldn't have gotten informed consent to do this study, right? Because obviously even the experimenters didn't know what they were doing. So what happened there? It had 10 authors on it, including, and I should mention, one of the things I'm doing here, because of this business with human error not being a thing, right? When we see names, we tend to focus on, hey, yeah, that person, right? They screwed up, it's their fault, right? We're gonna put that aside. I'm not in any of this gonna make any judgments on whether or not, right? It's appropriate to impose consequences on individuals or anything, but that's not what this is about now, right? So for key names like this all the way through, I've just substituted something like this, just A, B, C, D kind of thing, so that we can focus on the bigger picture and on the systems. So yeah, one of the authors was on this WHO IPCR-DEG C19 committee, and I won't go into what all that stands for, but essentially that was the committee that drove the WHO's COVID policy for the first year of the pandemic. So this isn't just some random person somewhere that no one's ever heard of, right? This is someone influential, right? And bringing this influence into COVID policy for the first year, right? And again, we go into this in more detail here in our examination of that particular case. This one's relatively short. And so, yeah, what I've tried to do in this example and in the following ones is, rather than trying to understand this from N of 1, right, is to just break out, well, what were the failure modes here? What went wrong, right? And I'm gonna skim through that in a bunch of additional papers, and then come back and pile up all these failure modes in a heap and see if we can use that to understand the patterns and the systems level problems. So yeah, lack of expertise, obviously, right? Failure of peer review, gatekeeping, parochialism. And I separated that out, and what I mean by that is this idea that we don't need to, there's gatekeeping we don't want to know what you have to tell us. And then there's gatekeeping, this kind of parochial version of it, which is more, I don't know, it's not interesting. I'm not interested in knowing stuff from outside my little box, right? I don't need to know, I don't need to find someone who's an expert on N95s, I can wing it, right? Okay, so we got that. Okay, so another one. The idea that COVID isn't airborne, right? Back to this idea that, that transported large particles greater than 5 microns fall rapidly to the ground 1 to 3 feet, right? Sometimes 6 feet, sometimes 1 meter, but that's that claim that we've all seen in a bunch of places, right? So, and this specific one was from training materials used at a major Canadian medical school until mid-2024, when I reached out to them and told them why it was wrong. So, yeah, greater than 5 microns, fall rapidly to the ground 1 to 3 feet. The problem is that has no bearing on reality. If you look at the settling rates for particles, a 5 micron particle, something just a little bigger than that maybe, right? It's gonna take half an hour to fall to the ground from head height. It's gonna go way farther than 3 feet, right? It's not at all behaving like a little cannonball. And even by the time you get up to 100 microns, we're looking at a 5-second fall time, right? So that's pretty long, and this is in perfectly still air, right? The air starts moving around, convecting, people walking around doing things, could be up for ages. And then it gets even worse from there, because on top of the fact that it takes a long time to reach the ground, This is in perfectly saturated, full humidity air, right? But in drier conditions, like we get in any normal space, they're going to be evaporating. And the surface area to volume ratio on these tiny little particles is really, really high. So they evaporate quickly. And it's actually a race between, does it hit the ground first? Or does it shrink to a size that can float around for a long time indefinitely, right? So here's kind of the data on that. So you can see, like on, these lines I think are meant to kind of represent falling particles. You get larger than about 0.1 and 0.2 millimeters, right? They're going to hit the ground first. Smaller than that, they're going to kind of succumb to evaporation and basically wind up in a condition that can float around indefinitely. So remain in the air as droplet nuclei with attached infection, right? So, and you can see this is kind of like, obviously that's not the latest in fonts, right? I scanned that in. Received for publication June 14th, 1934, right? So that is not new information, right? And then if we go to the SARS Commission, so that's looking at what went wrong with management of SARS-CoV-1, right? Which is obviously SARS-CoV-2 is going to be related to that, right? Kind of the same thing. No indication that this 3-foot rule takes into consideration evaporation and drift. No scientific evidence in explaining the rule. Applies only to droplets greater than 50 to 100 microns. Illogical and not particularly helpful from a disease transmission perspective. So we knew this stuff in 1934, and it's not just something obscure that only specialists in the field knew about. It was, it's pretty common knowledge scientifically. So why is medical policy based on this stuff, right? So human error, I mean, obviously, right? But again, that doesn't get us very far. It's nearly a century out of date, right? Like the people making the error were not born. And this was like, it was wrong when they were born, right? So it can't be an individual human error when it was known to be wrong before any of them were born, right? And it, again, highlighted by the SARS Commission, yet it was repeated publicly by a lot of public health leaders. So outdated information, lack of expertise, failure of peer review, gatekeeping, parochialism, and also authority, kind of saying, oh, we don't need to know about this stuff. Okay, so claim N95s aren't better than medical masks, right? So this is actually a press release put out by McMaster University, and that was their title: Surgical Masks as Good as N95s for Healthcare Workers Providing Routine COVID-19 Care. And it doesn't make a lot of sense mechanistically, right? Like they've got the big gaps at the side, aerosols float around, but as a randomized clinical trial, it offers the highest standard of evidence, right? So, okay, we'll come back to that. That was a study, and this is from their protocol. If they demonstrate this outcome, it's going to provide experimental proof to support a policy of using medical masks. And this is a protocol written by a team who were, in many cases, responsible for the policy of using medical masks, right? So, okay, yeah, there's a bit of a conflict of interest there, right? Like, raised a few red flags already. So then, looking at the study, if you're familiar with clinical trials, basically to prevent manipulation, because it's just too easy afterwards to say, oh, well, we meant to look for this, or we're going to, we need 3 more people in this, you want to pre-register the trial and specify, hypothesis, data collection, statistical analysis, all that stuff in advance. And then you do your tests, right? So the pre-specified sites were in Canada and Israel. They showed the expected benefit of N95s. We've got 14 versus 7 COVID cases within these groups, 300 people altogether at that point, which was just over 50% of the total. 576 was the pre-specified enrollment.
What's ISR?
Sorry, where? Israel. Oh, Israel. Yeah. So the two. Yeah. So these are the. Yeah, I should explain. Okay. Yeah. So cases in the medical mask arm in Canada and Israel. Cases in the N95 arm, and then this right-hand bar is on the right-hand scale. So you can see just between the two of them, they add up to just over 50% of the pre-specified enrollment. So there was some major ethical concerns raised in Canada, and the study was shut down and moved to unregistered sites in Pakistan. So that's not great, right? And there actually it kind of gave similar results, and they got up to 84% of the target N, right? They could have kept going a little bit longer, enrolled a few more people, wrapped it up. And there really was no plausible data in that last 16% that could create an outcome of non-inferior, right? They were actually pretty close to statistically significant demonstration that N95s were actually inferior, or superior, sorry. So there really wasn't, in this last little bit here, it really wasn't plausible that they'd suddenly balance that out. But instead of finishing it off like that, what happened was they moved the entire study to unregistered sites in Egypt during the Omicron wave, right? And everybody was taking off their masks, taking off their N95s, going home, elevators, buses, apartment buildings, right? Exposed to, right, because Omicron, it was everywhere. So essentially the trial at that point was just comparing not wearing your medical mask versus not wearing an N95, right? Like there was nothing there, right? You can see from the size of the red bars that they absolutely swamped out everything else, and particularly the results from the registered sites. And of course, the numbers shot way past the original enrollment. They enlarged the enrollment up to 1,000, and et cetera. And this is just the tip of the iceberg. So it didn't reference even the OHS engineering PPE literature. It didn't reference the standard, even though the study was taking place in Canadian hospitals. Major changes to the study all the way through, all biasing the outcome in the same direction. The mechanistic issue. And it was originally designed as an intermittent use trial. So when providing care to, or when within 3 feet of a patient with any febrile respiratory illness. But the idea here is it's supposed to be PPE against an aerosol, right? So the 3 feet isn't particularly useful, right? And just like you don't, walk into the construction site and they say, oh yeah, there's some walls in here with asbestos, right? And then wait until you can get a good smell of it and say, oh yeah, okay, I should put on my PPE, right? You want to be wearing that in advance. You want continuous wear. So this isn't even, and this is a complicated and interesting backstory about how they got here, thinking this was a good protocol, but anyways. So yeah, ignores the real aerosol behavior and also ignores asymptomatic transmission, right? Because if someone's there with a broken leg or something and then they've got COVID, but they're actually not really sick from the COVID, you wouldn't know and you wouldn't put it on. So then the reported finding of non-inferiority, entirely a product of data from the unregistered sites, particularly, like specifically Egypt, it's all Egypt, and a whole bunch of additional changes to even definitions of basic terms, the hypothesis, the analyses, and each of those changes is necessary but not sufficient. And they were added to the trial registry retroactively after the paper was published. The data from Egypt, which is, again, if you take that data out, it reverses the outcome of the trial, and there's statistically impossible patterns in there, like just stuff that's not going to happen in real data. And the details, again, if you look down here, if you want to really deep dive, it's all in there. There was even a statistically significant bias towards assigning female participants to the medical mask arm. So randomization was broken right off the bat, never mind all the kind of equity concerns and everything that raises as well. And how did that happen, right? Is that because, did male participants manage to pull some strings to get switched over to the N95 arm? Like, who knows, right? And then actually, just to put the icing on the cake, earlier, just a couple months ago, a couple of the authors published a 2022 data set, so something they had in their hands prior to publishing this study, that showed the large majority of COVID transmission in shared hospital rooms is airborne and prevented by good ventilation. So I don't know why they were sitting on that for 3 years. I mean, I can speculate, but anyways, there's that. So again, human error, I mean, yeah, and then some. But again, Annals of Internal Medicine is a mainstream medical journal, and there's just so many things wrong with this, right? It's not like one little thing, right? What happened to peer review, publication funding, ethics, et cetera? 31 authors, including 2 more that were on that WHO committee that was setting policy, including Dr. D here is the chair, right? That was making WHO policy for the first year of the pandemic. So, what happened? Again, breaking out the pieces, right? The same thing we've seen before, and this gold standard thing, right? Like there's this, you run into that a lot in the evidence-based medicine space, and you see it in press releases and things that a randomized controlled trial is a gold standard, right? It's automatically good, and that's a bit problematic too. And interestingly, this fundamental, like the intermittent use, right, walk up to the person, inhale the aerosols, then put on the N95, is also shared by a 2009 and 2019 RCTs of N95s comparing against medical masks and influenza. So those are the big 3 trials that like CDC was using even before, you know, the real crazy people kind of got in there now, right? And all 3 of them were designed around, like, they just didn't know how to use the PPE they were testing, right? So again, there's a problem. Okay, so where does it go next? Like once a paper has been published and it's got these claims in it, right? Like, well, you know, one could hope that when it's rolled into, when people are making guidance and things, that, you know, maybe they would pick up on this, right? Okay, yeah, there's something wrong with this one. We're not going to use this one. Okay, so this was, again, this WHO committee, a paper written on behalf of the committee, signed by the committee, but the lead author and the person who wrote the first draft is the chair. In summer of 2020, justifying the opposition to N95s. An additional study has suggested pregnant women were not able to maintain their ventilation, decreased oxygen uptake, increased CO2, effects on the developing fetus are unknown, right? Sounds really scary. But again, if you follow it, and in this case, it's actually reference 67, 55 here has nothing to do with it. They just got the numbering mixed up. It doesn't even talk about pregnancy. It's totally unrelated. So this links back to that 10 N95s at once pregnant nurses study. So again, lack of expertise, lack of rigor. And it's interesting, in the same paper, they actually explicitly acknowledge that the precautionary principle requires that they go with respirators. But then they say, oh, but we actually don't think we should. Okay, again, with the masks are harmful. According to Padilla Hernandez, now this is a different author, right? This is not someone who was on that study, the 10 N95 study, right? The use of masks, especially N95s, adverse effects on the cardiopulmonary function, fetal oxygenation, right? Again, scary, right? Okay, well, when you go digging into this, and it turns out that this reference 32 is a Spanish language review that you can't get online. So there's a whole transparency thing there. But I did manage to get the university librarians to chase it down for me and get me a copy. And then my sister speaks Spanish and a few other people I know, so I got some help there. And yeah, so it actually, even though it sounds like it's a review that found this thing, actually when you start reading it, it only relies on this study and a 2020 review. And then when you dig out that 2020 review, it relies on this study. So it sounds like there's sort of this emerging consensus or whatever, but you trace it back and it's actually to this one study that is ridiculous, right? Okay, so, you know, broken telephone, reliance on secondary sources, lack of expertise, lack of rigor. And this was CAN-PCC. So that is a collaboration between McMaster GRADE. So GRADE is this evidence-based medicine approach that was, and a lot of EBM stuff was developed at McMaster. And then Cochrane, which is the other big information provider in the EBM space. And they had $9 million of federal money to do a bunch of these things, right? So this really should be the pinnacle of evidence synthesis, right? Like these are the 2 big names in the field, the people who came up with the main techniques that are being used commonly throughout the world. And they had $9 million in funding, right? It wasn't like they were doing this on a shoestring off the corner of somebody's desk. Okay, COVID isn't airborne. So this is a really interesting story here. But essentially in April 2020, the world's top experts in aerosols, bioaerosols, aerosol disease transmission, went to the WHO and said, okay, we need to stop with this droplet thing. We're pretty sure it's aerosols, and we really need to start taking some precautions around this. Like, why is this not happening? And so Dr. Moravska here, who she's won all these awards a whole bunch before this, and I think just got the Australian President's Award or something like some very, very prestigious, very respected, everybody in the field knows who she is, that kind of thing. Just got cut off, right? Just shouted her down and started explaining that, yeah, okay, airborne only applies to particles smaller than 5 microns. Right? We're not interested in what you have to say. We know, right? So this is actually the chair shouting her down, cutting her off. This is a screenshot from Carl Zimmer's book, Airborne, which I think, does the library have a copy of that? Maybe? Okay. Yeah, it's a good book. Definitely worth reading. It goes much, it starts like centuries ago kind of thing. It just goes into aerobiology, airborne disease transmission, and things. Super interesting, very well written. But anyways, this is the same incident, right? So again, chair of the committee screaming at her, where's your evidence? Where's your evidence, right? So here's April 3rd, 2020. Basically a month later, so this is, again, the chair of that committee making a presentation. And so screenshots from his presentation, it's contact and droplet, it's not airborne transmission. He knows this, right? Not airborne transmission. And emphasizing droplet is larger than 5 to 10 microns that fall within 1 meter. It's got to be smaller than that for it to float around. And again, here is from that 1934 paper. That's in quote, right? So 86 years out of date, having just shouted down the world's top experts who were trying to convey that information, right? So again, what are the components? Well, obviously bullying is an issue here, right? People who feel they can just shout people down. It, does not escape our attention that here's a senior guy and here's a woman being shouted down, right? Lack of expertise, outdated information, gatekeeping, and then some additional red flags here around the involvement of leadership and this, there were more than 2 people in the room, right? I mean, it was a big video call, right? So why were people just sitting there, right? And the idea that there's actually somehow an entitlement to do that, right? That this guy was entitled to shout her down and say, well, I'm not interested. Okay. N95s aren't better. 2023 Cochrane review, I won't go into the details, but yeah, medical mask, non-inferior to N95 respirators. There was significant overlap in the authorship, well, senior authors the same. Last author is Dr. D. The first author, if you follow that link, there's a story on him being paid by these anti-PPE groups, various other controversies. Again, failures, I won't read them all. But again, Cochrane, right? Like one of the big names in the field. WHO COVID guidelines, again, the only RCT of medical masks versus respirators. It's magical, right? We don't need to worry about how good it is. Again, all these things here. And coming back to this, well, it's a randomized clinical trial, it must be gold standard, right? And failure to manage conflicts of interest as well as an issue. Okay, back to CAN-PCC again. So addressing raised limitations of evidence used, 11 by the public. I'm fairly sure that's me, or at least partly me, because I did in fact raise some of the issues with this study. And they took a look at it. So this is that medical mask versus N95 trial that went off to Egypt and did all those things, right? Best available evidence, rigorous assessment of the study by the evidence synthesis team did not find risk of bias concerns. And I would be disappointed in a mid-program master's student who told me that after reading that paper, right? Like, it just does not compute, okay? So again, right, looking at the components, and again, we're back to, wasn't like they were doing us off the side of their desks, $9 million, the biggest names in the field, should be representing the pinnacle of evidence synthesis, right? Okay, so what happens when we try to fix it, right? So we went to the journal that published this paper, and we informed them of the problem. And initially, we got a positive response from the publisher's research integrity team, and then they forwarded things along to the journal's editors, and then things kind of went downhill from there. They said, oh, well, we're not going to retract, we're not going to correct, we'll think about publishing your letter pointing out that the entire study is invalid. They sent it out for review, and then these are quotes from the reviews, there were a couple of them. Have not demonstrated any methodologic flaws. I mean, again, like, here's our thing. If anybody wants to, you can click through there and have a look at it. And if you find anything wrong with our logic, I'd love to know about it, right? But it's pretty straightforward. But they said there's no fundamental error. And it was a really interesting kind of revelation for me because as near as I can tell, in a different part of the review, the reviewer is actually claiming that you can't assume that physics, like mass balance level physics, conservation of mass, right? You can't assume that that holds true in a clinical setting. And it was just like, what? You keep rereading it and thinking, is there a different way I can, but no, right? So anyways, yeah, pile up some more of these, right? COVID isn't airborne, right? So I mentioned I told the medical school about how this was a problem and it was decades out of date and all these things. Well, they took out the explanation of why they said they didn't need to put N95s on medical students, right? But they didn't actually change the guidance. And when I followed up on that, I said, well, your justification's wrong. Like, you have to reconsider like what you're actually teaching the students to do, right? We follow the guidelines from the provincial health officer. I'm in no position to be telling her what to do, right? So again, all these things, and in particular irony, the provincial health officer's annual report in 2024 actually recognized that the things are like COVID's transmitted in aerosols. But the guidance still says, oh, you don't need N95s because it's, I don't know, left over from before or something. And well, if the piece of paper says we don't need to do that, and there's no erring on the side of caution or anything like that, it's just, follow the line. And so this kind of brings up lack of contingency planning, right? Like, what if you're wrong, right? Like, maybe could we take some extra precautions just in case? No. Okay, so there have been a ton of efforts to do something about this medical mask N95 RCT. And again, it's just so screamingly bad, right? Bunch of international experts in 2021 ignored, including by the Secretariat for Responsible Conduct of Research, which is the entity that is supposed to be doing something about this, right? Criticism submitting to the journal went nowhere. They were kind of thrown out, and the editors actually wrote a letter saying what a wonderful study it was. They said, oh, well, there may be some limitations, but because the study admits that there were limitations, that means it's all okay. And most recently, presumably in response to some of this stuff, the journal actually added an expression of concern on the paper, but weirdly, they let the senior author of the paper write the expression of concern about his own paper, which I've never seen that before, right? That is not normal. And in that letter, he said, participants had received verbal instructions that were different from the written ones, and they don't have a record of it, as far as I can tell anyways. It wasn't mentioned anywhere. And again, like how is that allowed, right? That you can just say, well, yes, okay, well, we gave them these instructions, but actually we called them up afterwards and said, do something different, right? Like, that's not science. That's not how science works. So again, piling up the pieces. Failure to manage conflicts of interest. And this was just kind of a illustrative social media interaction between, again, I blanked out the names, right? But here's a PhD mining engineer, and then an infectious disease doc saying, in complete honesty, I strongly suggest engineers should not tell ID docs, infectious disease docs, and infection control docs how to manage PPE and outbreaks in hospital. Like, of all the people to say, I don't have anything to learn from you about PPE, a PhD mining engineer, right? Like, that's an area they're going to know a lot about, right? So again, this just sort of parochial approach that says, oh, no, I have everything I need here. I don't need to learn anything. So how do the pieces fit together, right? Like, what happened in the big picture? How does this story kind of come together? So at the beginning of COVID, we had that very big mistake, right? The one that cost an enormous number of lives that, again, the WHO chief scientist was talking about. And it was immediately panned by everyone, like, the people who'd worked with the SARS Commission, medical experts, precautionary principle, like everyone just kind of said, no, that's terrible. You can't, that's a big mistake, right? And then the experts went to the WHO and all of this, and it just kind of got firewalled, right? They just built this little bubble, and they said, well, we don't care, right? Like, Lydia Marowska can go off and, do whatever. We're not going to listen. And then, okay, so they did this study, right? And they said, hey, no, actually, it looks like that very big mistake that cost an enormous number of lives maybe actually wasn't such a big deal after all. Because, the big thing we would have done differently is given everyone N95s, and we just proved that they don't help, right? So actually, maybe we didn't screw up that badly. And then that goes into reviews and guidance that come back and also say, yeah, it was fine. It's all good, right? And then between that and some of the other studies, you get media coverage that says, oh yeah, everyone's demonstrated that these things are fine, right? And then when you start looking, okay, well, so I substituted out the names, right? B, C, D, all that. The names, so these are, so again, D, 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 right? D. These are, so the letter is always the same person. And you start to realize that actually these are some pretty small little in-groups that are asserting control over, they kind of mark their own homework, right? They run the studies, they do the reviews, they roll them into guidance, they do media releases. all of that feeds back, and they were the ones that made the original decision, and says, oh yeah, no, it was good, we did the right thing. Maybe it wasn't such a big mistake after all. Okay, can we kind of break that down? We can see just again some of these same points, right, popping up. Okay, so then we put them all together here. And again, I'm not going to read through them all. We've seen them pretty much. There's a few extras here. Closed loop self-evaluation, right? So there's a problem. There's a lack of independence there, overriding the precautionary principle. And one thing you notice in here is there's very, very few PhDs, right? And what evidence synthesis is doing is it's saying, well, how do we interpret the science, right? And so, like, it has a lot of implications in the clinical space. But the topic is science, and it's kind of like, you know, the difference between building an airplane and flying an airplane, right? You need a pilot to fly an airplane, and you need a good pilot to fly an airplane, and it's a very highly skilled profession, and you need a lot of training and practice and everything else. But if you were to build an airplane and you were to say, well, we're locking all the aerospace engineers and metallurgists and everybody else out of the room, pilots only, I'm not going to get on that plane, right? It's just not going to work out super well. And so, yeah, like an MD, starting with the same undergrad degree, an MD is just as well trained to carry out research in a given area as someone with a PhD in that area is to practice medicine. Doesn't mean one's better than the other, doesn't mean one's worse, but it's very different training. And that doesn't seem to have been recognized or incorporated into the process of knowledge translation here. Okay, so why does this happen, right? Like, why do people think this makes sense? Because again, we can say, oh, human error, right? But that doesn't get us where we need to go. Okay, so this is the evidence hierarchy used by the World Health Organization. This is their official document. The link's down here at the bottom. This is slide number 10. For decision making during the pandemic, right? And well, there's a few things. Okay, so it started out, evidence-based medicine and these related hierarchies started out as a heuristic for making quick and dirty decisions, right? You've got a patient coming in a couple hours, and the first line drug doesn't work for them because they're taking something else. The second line doesn't work for some other condition. Third line similarly. So there is no fourth line drug. So you've got to read an entire field worth of scientific information in the next hour, right? Obviously, you can't really do that. So it's just this kind of heuristic for diving in and saying, well, okay, is there an RCT, right? I'm going to assume it's done well. I don't have time to do anything else. If not, I'm going to work my way back down. And at the very bottom here, if I really can't find anything else, if I find an editorial that says you should use this one, I guess I'll go with that, right? But obviously not really a scientific approach. And the problem is that, you know, it doesn't mean it's not useful. Evidence-based is better than not. But I really like this quote from Terry Pratchett, right? Around the God, in this case evidence, there forms a shell of prayers and ceremonies and buildings and priests and authority until at last the God dies, and thus may not be noticed. That's a good book. And that seems to be what sort of happened with this idea of EBM as a heuristic, right? Because it is still useful at that level. But it's evolved into this big structure with a priesthood and everything else. So they stuck systematic reviews and meta-analyses on top and clinical practice guidelines above that. And then down at the bottom, animal and laboratory studies, which is in practice taken to mean everything. Engineering, occupational health and safety, all fields of, like, you name it, right? So essentially, everything outside of science is below even the opinions and editorials of someone from inside this bubble. And so now we can start asking, well, okay, we've built up a pile of these failure modes, right, in looking at the various things before. Do they map onto this structure, right? Because this is the decision-making structure that underlies what's been going on. Does it have explanatory power? Well, okay, reliance on secondary sources makes sense, right? Because they're actually taught that this is the ultimate form of evidence, right? Gatekeeping, a couple different forms. Parochialism, yeah, why would you need to listen to people from outside your universe if their entire lifetime's accumulated expertise has less value than your opinion, right? Or an editorial you read last week. Up here, gatekeeping, RCTs are kind of the gold standard, right? Like the best form of primary evidence in this system. But actually, secondary sources beat them, right? And so now you can see, oh yeah, well, there's a real problem there with, like, once you've decided something, how do you undecide it, right? If it's wrong, how do you correct? Some additional bits like lack of expertise, very few PhDs. Again, why would you bother getting a PhD or putting a bunch of time in to get expertise when it doesn't get you anywhere, because your opinion is already better than that, right? You can see how that would lead to bullying and overriding the precautionary principle because, well, I've got an opinion. It overrides, I've made a decision. It's all good. RCTs up here, gold standard, there's a problem, right? Because there's this methodological bias, right? Like if I were to say, what is the gold standard, the best experimental method in physics? Like that's not a question that even makes sense, right? Like there is no one method that is just magically defeats everything else. You have to integrate the evidence. Again, as a heuristic, as a shortcut, it can make sense because you just don't have time to be thorough, but it's not a scientific approach. Outdated information. One of the things you'll notice going up the pyramid to the higher and higher levels is they take more and more time. So case reports, case studies, cohort studies, RCTs, reviews, clinical practice guidelines, months, years, right? And so now you're looking at a system where it is right from sort of basic definitions, it's backward looking, right? Nothing counts until the bodies pile up enough in statistically significant numbers to notice. And so it's kind of like driving your car with the windshield painted over by looking in the rearview mirrors. And if you're on a straight section of road, actually you could probably make that work, right? But when you hit this high velocity risk, when the world is changing quickly, when you've got a corner, you're not going to make that corner, right? Additional pieces, you can sort of see how these fit in, maybe not at a specific location, but the closed loop self-evaluation, because again, if clinical practice guidelines are the ultimate form of evidence, that's your ground truth, right? So of course you're going to close the loop on self-evaluation, because when you get an experimental data in, you're going to say, well, okay, we know this. Is this a good experiment? Because does it match what we know, right? And if not, well, there must be something wrong with the study. We throw it out. And it's interesting, like, I won't go into it here, but if anyone's run into Lysenkoism before, there's actually some really interesting parallels to like this idea of filtering information and knowing what the truth is before you do the experiment and all that. Okay, yeah, so going from there. So a lot of things start to make sense now, right? Rejection of knowledge from outside the bubble, well, it doesn't count, right? This idea of terra nullius, that was, the papal declaration that the Americas were open for colonization because the indigenous folks just didn't count, right? Same kind of idea. Studies conducted without expertise, there's this belief that randomization is just magic. Like if you just randomize, it cancels everything out. If you have controls, you don't have to understand what you're doing as long as you just randomize and have controls. Can't identify errors? Well, if you don't have the subject matter expertise, yeah, like you're not going to be able to find errors you don't understand. Bad trials being treated as a gold standard, well, the pyramid says it's the gold standard, right? So it doesn't really matter if it's a bad trial. Again, this like out-of-date information we talked about. Cognitive lobster traps. So this idea of secondary sources overriding primary sources. Once you've committed to an idea, that's why it's so hard to change. And I suspect that's at least part of the reason why this 5-micron error has persisted, for close to a century now. And again, this refusal to correct or retract is the idea that, well, any input you bring to the table is off the bottom of the pyramid. It doesn't matter. We don't have to consider it. We don't have to worry about physics or any of this other stuff because this is a clinical trial. It's better. And it gets worse. So this is a quote from the guy that started the whole thing, right? A big name in the field. There's only one serious limitation in grade, right? And that is the subjectivity involved in virtually every important decision. I don't even know what to say, right? And the problem is, EBM is being taught in many medical schools as how science works, right? And again, this is partly down to, like, med school's really busy, right? There's just not a lot of time to go into philosophical debates and philosophy of science and everything else. And so a lot of this gets rushed through, but it's taught, like, this is science. Not just here's a useful trick if you're in a hurry, but this is how science works. And so you combine those things, and we have a system that claims to replace science, throws out most of science, other than the stuff that's generated by the people who are kind of inside the bubble. And then when you're inside, if you have multiple RCTs, trying to decide which one's better, which one's worse, really what the process does is it helps you come to a consensus of the people in the room. So it's not necessarily telling you this one is objectively better or objectively worse. It's saying that, well, everyone who's sitting around the table likes this study better than they like that study, right? And so when you have the option of throwing things out, you can just, well, I don't know, yeah, that one's bad, no one likes it, get rid of it. And what that means is, you know, he who picks the pickers picks the cherries, right? Like if you decide who sits around the table, you can pick people who think in certain ways and you can get an outcome that you like. And we're seeing that now in the US around the vaccine debate and all that kind of thing, where RFK is coming in and just replacing people wholesale. And the challenge is that these systems are going to produce whatever result he's looking for without cheating. Like if you had to change the rules or something like that, there'd be something you could point to and you could say, oh, look, he's breaking it, right? He's not doing it right. But actually, just by changing who sits in which seat, you can get different outcomes. And it's going to be, I think, much more broadly and deeply impactful than a lot of people realize because of that. Because a lot of people have been taught that these are the big official sources that produce, you know, authoritative guidance. And you can see the language is already kind of showing up there. Koldorf, he was the chair of the ACIP, which is that vaccine committee. Gold standard science, this is RFK quoted here. Gold standard science, evidence-based policies, right? Pulling in that vocabulary. But it's, you know, it's very popular with authoritarians to have something that claims to speak for science, but where, you know, 2 + 2 can be 5 if you wanted to, right? And they're already like this. So these first two links, they're back to overriding the CDC, promoting uncontrolled transmission of COVID back in 2020. There's that famous quote where the guy said, we want them infected, right? He's actually an EBM guy from McMaster that published a bunch of stuff with some of the key figures there. And then now in the present day, everything from vaccine policy, trans healthcare, EBM processes are being used to just remake those on a purely ideological perspective. So I'll just wrap up with, okay, what can we do about it, right? So first off, look for the things everyone agrees on, right? Like nobody hates clean air, right? Like, I mean, yes, okay, there may be some costs in refitting an entire building or something like that, but there are lower cost solutions. There's those fan filter boxes and, you know, when you're building things, right, like, I don't know, the long-term care facility going up, right? Now would be a really good time to make sure that place has really good ventilation in it. So that we're not in a Vigie Santé situation when something happens 5-10 years down the road. Where people disagree, you know, misinformation, things like that, well, try to understand why, like rather than just saying, oh, well, they're wrong, right? Where did that come from? And also when somebody says, yeah, you got to take this with us or against us, this position or that position, I mean, they might want you to make that choice, but it doesn't mean you have to. Remember, human error doesn't really explain anything. And there are things, you know, you can start on right away. Are there shared spaces in town that could use some help to improve air quality? I believe you have one of those CO2 monitors. Yeah, so the library has a CO2 monitor that you can use to measure air quality, because in most of the spaces that most of us encounter most of the time, the main CO2 source in that space is other people, right? It's different if you're working in an iron foundry or in a barn or something like that, but most of the spaces we're in, if there's lots of CO2, it came from the people around us, right? And, you know, there's all the aerosols and everything else those people exhale in that air that we're breathing in along with it. So you can use a CO2 monitor with a little bit of, and I've got a couple of links farther on, where you can actually just kind of survey spaces and you can say, well, you know, is this one reasonably well ventilated? How about this one? Yeah, and I'll actually show a trace at the end, because when I did this as a keynote in Ottawa, I had my monitor, and there was an interesting bit in there. And even just collecting data, right, and talking about it, like, that's cheap, right? And just thinking about what it means, and, oh, well, you know what, this one place could, sometimes all it takes is opening a damper, right? Okay, and then build better open scientific processes. If you have relevant subject matter expertise, don't assume that guidance is coming from people who know that better than you do. You have to be careful because they might, right? So you don't want to just assume that you know everything better than they do, right? But it's worth looking. Like, the credentials are relevant, but ultimately it comes down to the quality of the science. So take a look at that. Peer-reviewed publication in a prominent medical journal is not proof of rigor. Again, that Lancet thing with Wakefield, it was up for 12 years. The examples that I've brought up here, several of which we have participated in efforts to get something done, and they're still up, right? And this is where like loss of public trust comes in, right? Because people can read those, people can see the failures, and then they kind of say, well, yeah, why should I accept these as authoritative voices if they got stuff like that in them? And it kind of, tars all the other papers in those journals as well. The thing about science is consilience, right? If you have multiple measurements, they're all from the same universe. There must be a way to reconcile them. It could be that somebody did something wrong. It could be that they apply under different circumstances, but you have to be able to reconcile them. Cherry picking is useful if you're trying to be really quick, but that's about it. Don't be afraid to reach out to people. And the one thing I wanted to emphasize is not the frontline staff that are the problem here, right? They're doing the best they can with the resources they have available. This is higher up the chain. So don't, go and yell at your public health nurse or something like that, because they didn't do it, right? It's deeper into the system. So build interdisciplinary networks. Learn about a bunch of these things, right? And again, I have some links. Learn about long COVID. Check the quality of research. And writing, like there's people here I think could, have the scientific backgrounds to maybe write in some requests for retraction and correction. This applies to Canada. It's not just happening in the US. So guidance to stop breast cancer screening for women, 40 to 49, produced using EBM approaches, is estimated to contribute to about 400 deaths a year in Canada due to cancers being caught too late. There was just something in the Globe and Mail about less than a week ago, I think, talking about how reductions in prostate screening are likely related to a dramatic increase in late-stage prostate cancers being caught too late to treat. So there's this years-long patient effort to bring this to the attention of ministers and things like that, and they finally, early this year, succeeded in getting the Canadian Task Force on Preventative Health Care paused, right? And this was really like, I got called in just to kind of provide a bit of support in a few points here. And I was in one meeting where there was a woman who was receiving chemo during the meeting. Like it was a Zoom meeting, right? There's all these people there. And she was in her hospital bed receiving chemo, trying to convince people at the top of the Public Health Agency of Canada and so on to really pay attention to this. And then the real tragedy of this is they succeeded. Everybody thought, okay, great, we're going to see some progress. And then the in crowd took control of the process of redesigning what was going to replace it, kind of elbowed all the patients aside and just grabbed control of it. They're now asserting that having expertise is a conflict of interest, not like being an employee of a pharma company or something, and that's how you got your expertise, but just the state of having expertise in your head is a conflict of interest, and therefore they're writing into the terms of reference for this entity that you will not be allowed to have a vote in the core CTF decision-making, right? And it's pretty transparently a way to just like lock everyone but themselves out of the room, right? They kind of market themselves as they have their magic checklists, they have their magic pyramid, and they can interpret any kind of science, but anyone who might actually understand the science is not allowed in there because it's, a COI. And they're also building up the structure to look, it looks like they're going to be funneling a bunch of money to, essentially people inside this in crowd. And again, CanPCC got $9 million just for long COVID. So we're talking, what is that? 7, 8, 9 figures worth of government money over the next decade at play here. So that's pretty serious. I could imagine there being a procurement scandal showing up a few years down the road. So that might be something you might want to talk to people about. Again, follow the links, right? Don't just do stuff because I say it's a good idea. Read the links, understand it. And, okay, so I'll wrap up there. I won't read these off, but these are references that you may find useful. Again, we'll distribute this as a PDF. I really tried to focus on mainstream sources, right? So we're not kind of anything weird out there. Chief Science Advisor, US National Academies of Science, Engineering, and Medicine, OECD, StatsCan, OSPE. Okay, so that's it. Acknowledgements, dedication, right? That enormous number of lives. And it's still ongoing. And I mentioned about, CO2 monitors. When I gave this talk in Ottawa, I had my CO2 monitor switched on. This was up at the podium, away from everybody else. I could see people at the back of the room just like kind of sweating, right? Like it was getting stuffy in there. I made a comment about it. Somebody went out and flipped a switch, I went over to the front table, so it's maybe a little bit lower there, down a coffee break, and then it stabilized up here after the break. So again, this is the CO2 levels, but that's a proxy for how much of the air you're breathing is something somebody else just breathed out, right? And it's just one switch. So just like data collection with those CO2 monitors is extremely powerful. So how are we doing here? It's 8:20, so maybe if anybody wants to just go, we can take a little break and give people time to, and then I'm happy to stay and answer questions, and at some point we have to let Naomi go home. But
How about 10-minute break so someone can open the door and bring the level down?
yeah,
And then we will go for questions.
sure.
So, questions? John? John?
Here we go. How does the risk compare to previous situations like polio and TB?
So I think, so probably we caught that one, on the recording? Yeah, okay, so, so I think there's two pieces to that, right? There's the acute, and then there's the long-term consequences. Generally, with vaccines, the acute consequences of COVID are less now, right? We're not getting those gigantic waves where people are dying left, right, and center, and the hospitals are full and the ICUs are full. And it's a bit unfortunate that we started using that as a metric, because now what's happening is it is that kind of long term. If you look at in this one, do I have a mouse? Oops, no, okay. I use the laser. This one here, Statistics Canada. This has some good numbers around the number of people that are impacted by long COVID and the duration of impact. And so this is the OECD report that I was talking about with. I'll make the file available as a PDF afterwards, and so you can download it off the website and follow the links. But that's the one that talks about every year, just in the OECD, 7 million years of human life lost to long COVID, and on the order of $1 trillion from the economy, 3 million people out of the workforce. So I think it's actually a big driver of a lot of things. Like if you look at inflation, right? Like what's going to happen when you have a bunch of people who are out of the workforce but still need to eat and buy things, and right, like you've got an imbalance between productivity and consumption, so you're going to see inflation. I think there was some really big spikes in immigration, and part of that was around the fact that workers were just kind of being viewed as disposable, right? And so you lose people and you bring in someone else, and then they get sick, and you're not going to take care of them either, right? And so there's a lot of recent, I guess, waves in the political space that, when you start to dig down, go back to the fact that we're still kind of in the middle of the biggest mass disabling event, in history, probably.
Richard?
Isn't it usually about all of the money or about money? So long-term care centres got a tile roof that's it's a fire hazard, whereas a tin pitched roof is not a fire hazard and costs more money. PSA and earlier breast cancer screening costs money. And when you clean the floors, the droplets on the floors, they're doing that anyway. So you don't have to spend any money, right? On PPTs.
No, I think, there's definitely a financial component. One of the things that's come up a lot in the breast screening stuff is that, if you don't screen and people get cancer, you actually wind up spending a lot of money on them, right? But it comes from somebody else's budget, right? Like a different part of the healthcare budget. And it comes from a future budget, right? So I think there is definitely that. I think there's a lot of these predispositions that have kind of facilitated. And then I think, the really big problem is that, if you picture somebody, there's this new disease and you say, no, I'm certain it's not airborne. We don't have to worry about it. It's all good, right? It turns out to be airborne. It's infecting people all over the place. Then the next decision to be made is, well, is it really serious, right? Well, there's going to be a bias, like even unconscious, right? Even with the best of intentions, there's going to be a bias to say, well, it's probably not that bad, right? And if you look at that cascade from, COVID isn't airborne. Okay, well, maybe it is, but it's not that bad. Well, maybe it is, but it doesn't affect kids. Okay, but they don't get long COVID. Well, actually, kids do get long COVID. Well, it's just a small proportion. Oh, actually, it's growing, right? And so I think that's part of this cascading failure. Like if you look at the Canada's chief science advisor, fairly diplomatic language, but said that there's gaps in public communications around prevention of long COVID. And I don't recall one part of the federal public service calling out a different part of the federal public service for not doing its job like that, other than maybe like somebody failed an audit and the Auditor General's going after them. It's diplomatic, but it's still like, you don't see that happening. And I think it's, that the people that told us it was going to be fine and it's going to be all right and it's over and it's going to go away are also the people whose job it is to tell us how bad things are now, right? And there's a conflict of interest in there that, the financial is relevant, but there's also these other components. It's the same thing with the breast cancer screening thing, right? We've had that guidelines for a decade, right? So if you're estimating 400 women a year dying from that, 4,000 over a decade, now we go into a grade evidence. So EBM, Mike asked me to explain, EBM is evidence-based medicine, and grade is just like a category of that. But you go into these EBM processes, and a study comes in, and the people sitting around the table are effectively being asked, this study indicates that you made a bad decision that has killed 4,000 people. Is this high quality evidence? And again, even with the best intentions in the world, there's going to be a bias to say, no, it can't be, right? That's part of the issue with subjectivity and these really limiting power to these very small groups. Then it winds up being the same people, marking their own homework.
And just remember, folks, hold the microphone fairly close to your mouth so we can hear you. Thank you.
One report that really had an effect on me was the autopsy report early on in the COVID days of just what parts of the body were affected by COVID. And I can understand very well why such a thing as long COVID.
Yeah. For sure, yeah. Like one of the big things about COVID is it turns out that we think of it as a respiratory disease because that's the obvious symptoms and that's how it's transmitted. But actually, the virus infects the lining of the blood vessels. So it goes everywhere, and many other cell types as well. But that means it impacts every part of your body that has blood vessels in it, which is basically everything, right? And so it is a little bit like back in the 80s, if you look back at some of the stuff when HIV was just starting to appear, and people were saying, no, it's one virus can't cause all that range of things. It's just not realistic, right? But then you realize, oh, well, it's knocking out the immune system. And secondary to that, all of these other things come in. And yes, it is actually the one thing causing it all, but people had trouble with that. And it's a bit the same way with COVID, is it hits the lining of the blood vessels, it impacts the immune system. It has all the, like if you look at, there's these spikes in influenza and RSV and things that may well be secondary, at least in part, to the fact that everybody's immune system's taken a beating from COVID. So yeah, and if you look at that, the second link there, National Academies report, you'll want to probably start with the summary tables because it's a gigantic report, but the lists of things that COVID has been shown to do, because it just goes everywhere. And we don't even know for sure, like I know of at least one situation where they discovered they were following wastewater. So in the sewer system, and they found that there was a a strain of COVID. So somebody was going to the bathroom and producing a strain of COVID that hadn't been in the area for a year and a half. And they tracked it back to one particular building and then I guess couldn't narrow it down any further. But somebody had a gut infection with COVID at least a year and a half after they got the respiratory, and it continued, they could, during the period they were tracking it. So, I mean, I don't know, like, if you've had COVID, how do you know it's gone for anybody? I mean, probably is, but at least in some people, but yeah. Oh, she's just reminding me to hold the mic up better.
Well, COVID's not really in the media hardly at all right now. So right now, currently, presently, today, how bad is COVID and what is our risks? Because we don't really think about it much.
Yeah. I mean, it seems to be building up again. It's hard to say because there's no testing. Levels are significant. People are still getting long COVID. People are still getting sick. I think, I mean, from the StatsCan numbers there, the fourth link down, every reinfection is a new roll of the dice. So, not getting it ever is best. Getting it once is better than 2 times. 2 is better than 3, and that kind of thing. Yeah, I mean, it's significant. I think in Deep River, you're maybe a little bit more, like if there's a pulse goes through, you might have a period where, either people got it and are, have a bit of immunity for the next 3-6 months, whatever year. And if you're lucky to miss it during that period, then maybe you don't get it the next time. I mean, I wear this now, my wife's immunocompromised, but I would just wear this everywhere when we go out with very few exceptions. And it seems like a big deal, but you get used to it. And there's, like, if I needed to, I could drink some water, take a breath, drink, put the mask back on, exhale, flush it out, and it just becomes habit. So, yeah, I mean, it's hard to say what the exact numbers are, but I think, I mean, do you want to?
Do you have easy access to Goja's charts to show the long COVID prediction?
No, actually, no, I'd have to fire up the browser and stuff. But yeah, there are some, I can actually, when I put the PDF together from the slides, a colleague of ours has actually done some projections on long COVID rates and things. And yeah, I mean, it's not, from an acute hospitalization perspective, we're obviously much better off than we were right at the beginning of the pandemic. But if you ignore the acute stuff and just think about long COVID, I don't know that we're any better off really than we were a couple of years ago. And I guess the other thing that's worth knowing too is that while, again, vaccinated out in the community, the acute effects are one thing. The death rate from acute COVID in hospitals is much higher. And it kind of makes sense, right? Because people are in hospital for a reason, right? And so there is still an element of that kind of thing. Like if you're going into a hospital, right? Like certainly I wouldn't go anywhere near an ER without one of these on. And so if anyone's interested, actually, there's like Ontario company makes these things. Canada Mask with Canada MASQ. And there's this new national standard, the Q100, which is a flow resistance standard, like basically a low flow resistance. It has to be easy to breathe through. And I find them quite comfortable. One of the challenges with N95s was that the early ones were designed exclusively, as far as I understand, for Caucasian male faces. Back in whenever it was kind of thing, and people thought, oh, well, that's who's going to wear them. Or at least the ones who kicked up the biggest fuss when it wasn't comfortable. And as a result, anyone who has a different face geometry who tried to wear one of those old N95s had to reef on it really tight to get a good seal. And so that's part of where the idea comes from, that these things have to be uncomfortable and, by the end of the day, your face is all messed up and everything. Because yeah, like if you don't have a stereotypical Caucasian male face structure, then you're just bending it on, right? Now there's a lot more options available, and you can get like these sampler packs from these companies as well, and till you find one that's comfortable, not just usable.
Okay, well, suppose two people get COVID and one has received COVID vaccination and the other hasn't. So the one who's vaccinated, he could very well be resistant to the virus and shows no symptoms and doesn't know it, doesn't see anything,
right.
Self-isolate, but he's still carrying the virus, whereas the person who was unvaccinated shows symptoms and knows he needs to stay home. So is it possible that receiving a COVID vaccination can actually make you more likely to spread the virus?
Well, so I guess, I mean, if you look at a population average level, right, like I'm sure, 30 million people in Canada, I'm sure it has happened, right? But on a population level, because the same thing could happen after you've got COVID once and your immunity is waning and then you get it again. But, not a particular, and I'm actually quite concerned about that happening in schools. I suspect there's a lot of, just enough of it circulating that kids are getting reinfected. And, their kids are reasonably robust most of the time. And so I think kids may be getting more infections than we realize. Not so much from related to not noticing because of vaccines, but not noticing because they're getting reinfected as soon as they possibly can get reinfected. Now, I want to emphasize that's just like a hypothesis at this point. So I don't want to be telling people that is happening, but that is something I think we need to be looking at. There was a big study out I just saw, I haven't actually read it, so I don't want to put too much weight on it, but I think they said a 75% reduction in mortality from the vaccine. And there are, at least for a period after you've had the vaccine, that's why you need boosters, but there are reductions in the likelihood of getting long COVID as well. Yeah, so this is the other thing. And it's interesting, actually, a colleague of mine who was involved in working on SARS-CoV-1, 20 years ago, in, I think it was March 2020, right? So before anything had hit, he said, oh, well, we know it's a SARS-CoV, so that tells me a couple things. One is probably immunity is going to wane, because that's how these things work. And the other one is it's going to mutate quickly, and we're going to have a lot of strains. And yeah, that was one of the big missed opportunities around not catching it early, is that once you let it get out into 1 billion people, right? I think I saw a number somewhere like 10 to the 11 virions per infected individual, right? And each of those is an opportunity to mutate the genome and develop a new strain, and then it spits out and we get the next wave and the next wave. And so there is a reasonable argument that if we treated it as airborne and really hammered on it right from the beginning, we may have actually been able to stop it, like prevent the whole pandemic, right? Like stop it. I mean, whether you completely eliminate or at least, to have some flare-ups here and there, but we're at total excess deaths worldwide around 25 million now. There's big error bars around that, but the line in the middle has passed 25 million from COVID. And yeah, it conceivably all could have been prevented if we'd caught it early.
Could you speak into the microphone?
I wanted to ask if we should have rapid test kits made available again. Because a few months ago I had a really nasty illness, but I had absolutely no way of testing.
Yeah. So yeah, there's a couple things. There's value to having those rapid tests. One of the challenges is that there's enough false negatives in them that it sort of depends what you're doing with them, right? Like if you're collecting, like first off, we should be collecting data. Like that's one of the things that just kind of as a scientist blows my mind, that we're just not collecting data, right? And there's a real push, and and it's actually explicitly stated in a lot of the public health discussions that we should only collect data if it's immediately actionable, right? Like if we're not going to do something right away to that patient on the basis of that data, let's not collect it. And again, as a scientist, it's just, no, like that's not how you do things. We've actually got, there's a system that is licensed in Europe for use with humans, but they haven't yet got Health Canada approval. But the, what's it called?
Pulse Life.
Plus Life, yeah. So this Plus Life system that essentially is as accurate as a PCR test. And that one's nice because, occasionally we'll have family over for dinner or things like that, right? And we just test everybody a few hours ahead of time and just kind of make sure that nobody's, asymptomatic or anything like that. And then you can be kind of comfortable taking the mask off and having dinner together and that kind of thing. So hopefully they'll get some of that more, like it was kind of a pain to get a hold of, right? It is approved for Europe, but they just can't sell it for, I think they were selling it for pet use or something to get around that, but then somebody figured out that they were doing it,
Well, they've stopped testing the sewage water, haven't they?
In some places there's some academic labs, particularly in like civil engineering departments and stuff that aren't involved in the medical politics side of things. Because when you think about it, and I've actually, there was a really good article, I didn't link it here, but in I think 2021, that said one of the big problems that public health faces is that it's actually really an engineering discipline. That if you look at water treatment and stuff like that, right? Like that's a systems level thing. Medicine is mostly about fixing the one patient to fit into the world as it is, right? Like the patient comes in and the world is this and they have an injury, they have something that makes things not working. And so the mission there is to change that one person or their immediate context to improve the situation. And that's a very different thing than engineering, which looks at, okay, well, how do we change the world to make it better suited for the people who live in it, right? And in contrast to most other areas of medicine where, cancer treatment isn't a statistical thing, like it's, okay, we need to treat this one person, right? But public health is actually more of an engineering domain and maybe needs to have that more systematic approach taken to it.
Can I try one then?
Sure.
Hello? No.
Mic is off.
Oh.
Give it a second.
Try to, thank you. I'm interested in the misinformation part of your talk. It took 12 years for the Lancet article to be retracted, but if somebody were to pick up a Lancet and not know it was retracted, they could still find the article. So how does the scientific community deal with retracted articles? Is there some universal place where you can get a list of everything that's been retracted? We all know about that one, but there's probably 100 others.
Yeah, there's a couple things. First off, there's a whole issue around what they call zombie papers that people keep citing, because they printed off a copy or saved a PDF or something before it got retracted and don't know. And so they're still actively citing these things after they've been retracted. So I don't know if you've run into Zotero before, Zotero. It's like EndNote and that kind of thing, but it's a free piece of software that is a citation manager. And you can get plugins that will actually connect to some of the databases and look for retracted papers. And so I have, I don't know how many thousand papers in my Zotero database. And there's a plugin for Word. So when I want to cite something, I just pick it out of Zotero and it fills in, whatever APA, nature format, whatever you want. So you don't have to fool around with that. And if you want to reformat, like, resubmit or something, just hit a button, it's beautiful. But you can get a plugin that will go through that library and put a little red flag next to anything that's been retracted. So there's that. Retraction Watch publishes major retractions, but they have a database with something like 50,000 citations in it, and I think that might be where Zotero is pulling its
Okay,
data from.
so there is a solution. Yeah.
Well, there are attempts, but it's still, like if you look up zombie papers and zombie citations in one of the search engines, you'll find there is a lot of concern about it still.
Thank you. Well, if there's no more questions, I think I would like to thank our speaker, and I hope you will, sorry, I'll learn. If there are no more questions, I'd like to thank our speaker, and I hope, I expect you will all applaud in the appropriate manner, and remember as you leave the building, the other way of thanking him. So, thank you.